to grade out the page, just enough to hold the grading bit at the junction of the spinal process of the lamina and confirm the location. It's a safe way to locate. Based on the position of the endoscopic position and the pre-operative imaging, informed image grading gel can be used to measure the range of the initial bone removal window to outside and the head and to the head. Gradually expose the proximal to our official ligament fluid with the grading gel. The junction with the lamina is the boundary of proximal decompression. Grade gel are used to expose to junction of the superior edge of the inferior lamina and the ligament fluid. That's the boundary of the distal decompression. Then remove debris of the base of the spinal process and contralateral lamina. There should be enough space to avoid the compression of spinal cord during the operation and ensure the safety of the operation. Gradually review the outline of the contralateral outfelt ligament flap. Gradually remove the outside axillary outfelt ligament fluid. Gradation of outfelt ligament fluid layer by layer. After confirming that there is no adhesion between the outfelt ligament fluid and duromat, the loose outfelt ligament fluid is lifted away from the duromat with a probing hook for removal, which is no invasive and safer for the spinal cord. Lift or loosen the contralateral outfelt ligament fluid and break it at the contralateral margin. After confirming that there is no adhesion between the outfelt ligament fluid and the duromat, loose of an outfelt ligament fluid is lifted away from duromat with a probing hook for removal, which is non-invasive and safer for the spinal cord. Then remove the loose outfelt ligament and complete decompression. This is not case is 71-year-old female patient with bilateral lower extremity weakness, and I started walking for 6 months, which gradually worsened and prevented her from walking for 1 month. So this is pre-operation, post-operation. Then CT, we can see there is a lot of severe spinal stenosis with post-procedure mortification. From the MRI, we can see that the OR caused severe spinal stenosis is the work portal and the portal. They come from the location in during the surgery. Consider the possibility of dural artification. The outbound ligament was ground as thin as possible, allowing it to float and achieve the purpose of decompression. During surgery, we did find that the area of the dural artification was light and couldn't float. So we cut the felt ligaments that have been ground to pieces from the middle so that they can float like the wings of butterfly. The agents of the affected ligaments that need to float should be completely loosened so that they can both float. Outside ligament from is full fluent. Decompression is sufficient. Then place 22. For thoracic spinal stenosis is a common adequate or even excessive decompression because it is very difficult for us to reestablish on the thoracic vertebra. So the patient was able to walk on the ground after 40 days after the surgery, but she couldn't walk before the operation. 6 months after operation, the patient's walking returned to normal, and the MRI showed that the dural march she also recovered well. This is another case with a 3-level TOR. This is T12, which is T23, which is 234. we can see the decompression is completely. This is um, 4 months after surgery. You can see the viewership is recovering. Can work normally 4 months after surgery. So I think the modification site of the ligament even was used as a target to establish the portal. The technique of safe use of grading gel is very important. The concept of non or minimally invasive on nerve should be carried out throughout the operation. With this dual auscultation, we can use the method of making it flow, and we can also achieve the purpose of decompression. The TOR-CB technique is subversive with clear vision, safe operation, sufficient decompression, less trauma, and good effect. The UB technique is a recommended method for treatment of TOR. So, thank you. Welcome to channel. Thank you.